Good evening, sir.
Good evening.
Welcome you all for this 26th issue of our Environmental and Occupational Health DigiConnect webinar. So today is 19th of September, Saturday, and may I request our President, Dr. Gajendra Kumar, to welcome and introduce the speaker and give us permission to start.
Audible?
Yes.
Am I audible?
Yes, sir. Yes, sir.
Hello.
You can start, sir.
Good evening, everyone. Dr. Sandeep, am I audible?
Yes, sir. You are audible, sir.
I have unmuted already and muted, but my voice, it seems I'm not getting any voice.
No, you are loud and clear, sir. We can hear you very well.
Hello.
We can hear you, sir.
Actually, I am not getting any voice.
Yeah. You can start, sir. There's no problem. We are hearing you.
Maybe I can. Should you drop a text to him?
Okay.
So there is some technical problem with.
I'm not able to listen to anybody.
Yeah.
No
so,
voice.
Yeah, you can
reboot.
So there is some technical issue with Dr. Gajendra Kumar, but we'll. So anyway, till Dr. Gajendra Kumar joins, let me introduce you.
I'm not able to listen anything.
So I will introduce you to our two speakers today. Dr. Rajiv Kumar Jain, our Senior Vice President. He is there with us for the weekly COVID epidemic, this EPID update, which is regarding this COVID-19 pandemic. And may I request Dr. Rajiv Jain to please start, then we'll start with the guest speaker, sir.
Thank you, Dr. Sandeep. We are actually going in a very difficult phase of the pandemic in India. Very, very difficult phase of the pandemic in India at the current juncture. I'm saying this because of number of evidences that are coming forward, as will be visible to you in the few slides that I will show now. If you see, India is almost on the verge of reporting more than 1 lakh cases in 24 hours to the World Health Organization. It is when other countries have started reporting less than 50,000 cases in 24 hours. We are on the verge of reporting more than 1 lakh cases. This is the WHO coronavirus disease COVID-19 dashboard taken only 1 hour back. And this is a real-time dashboard on the WHO website. Globally, at the moment, there are more than 3 crore individuals infected with COVID-19. And the United States had reported 66 lakh of them, and India has reported 53 lakh of them. While Brazil has reported 44 lakh, and Russian Federation 10 lakh, and Peru in South America 7.5 lakh. So you can imagine USA, India, and China, India and Brazil have reported 3 largest number of COVID-19 cases. But if you look at the next column, that is the cases newly reported in the last 24 hours, 3 lakh cases are reported in the last 24 hours, out of which 93,337 were reported by India. And USA reported 42,000 and Brazil reported 36,000. and no country reported more than 10,000 cases. If you see this figure, if you add on to the other 4 countries, India will still be higher. If you look at the total deaths in the world have been 9,47,933, out of which 1.96 lakhs have been by USA and Brazil, 1.34 lakh. India reported 85,000. But this is not that important as this figure, deaths newly reported in the last 24 hours. If you look at this figure, last 24 hours, the world reported 5,307 cases, 7 deaths out of 204 countries reporting to WHO. And India only reported 1,247 out of these 5,300. USA is reporting less, 827. Brazil reported 829. Russian Federation 134 and Peru 95 only. So India is reporting largest number of cases as well as largest number of deaths in the world. This is the reality today. So be on guard. This is a pan-India figure reported today morning.
Dr. Rajiv,
Confirmed cases 53 lakh, recovered 42 lakh.
Dr. Rajiv sir, you can share your screen. Your screen is not visible.
Screen is not visible.
Yeah, you have to share your screen.
All right, all right. I will do that. Thank you. Thank you for pointing out. Is it visible now?
Yeah.
Dr. Sandeep?
Yes, it is visible. You can start your presentation. Yeah.
Okay. Then I will show this figure again.
You can put it in the presentation mode.
I'll go back. This is the global figure I was telling you about. India reporting 93,337 cases, the highest by any country in the world, and 1247 deaths, highest by any country in the world. This is the COVID-19 tracker. Confirmed cases 53 lakh, recovered cases 79.3%, that is 42 lakh 800, and active cases 19.1. But look at the number, 10 lakh 13,964. Deaths 85,000, which is 1.6%. But if you look at this figure here, recovered percentages, if you look at the figure, kindly look at Chhattisgarh, 54% only. And look at Jammu Kashmir, 64% only. So this Chhattisgarh is a problem area today. Active cases are 45% of the total cases, and Jammu Kashmir 34% of total cases. That means this is active in that area. And kindly focus attention on Maharashtra. Even now, they are reporting 26% cases which are active. 3 lakh cases are active in Maharashtra. 3 lakh. While Chhattisgarh 36,000 cases and Jammu Kashmir 20,000 cases are active cases. Deaths, if you look at on the right side, 2.7% deaths in Maharashtra is still very high. And Delhi also 2.1, and also Gujarat 2.7%, 2.9% Punjab is a scary scenario. We need to study deeper as to what are the causes for this high rate of deaths in these cities and states. Let's go deeper. 53 lakh cases, 85,000 deaths, 62.5 million tests, and 10.13 lakh active cases. 92,969 new cases, 121 deaths yesterday, only 8.81 lakh tests yesterday, a 12.4% reduction. Can you imagine? In the current scenario, there was 12.4% reduction in tests, only 8.8 lakh. It was not a Sunday yesterday. and 11.7 lakh tests were done 2 weeks back. So why it is happening and where it is happening, we need to know better. This is another graph where we have, on each parameter, we have gone from highest to lowest, from top to bottom. If you look at confirmed cases, Maharashtra 21,000 still reporting. Karnataka, Andhra Pradesh, Uttar Pradesh, Tamil Nadu, Odisha, Kerala, Delhi are reporting more than 4,000 cases. Among deaths, out of 1221 deaths, Maharashtra reported 440, Karnataka 179, UP, Tamil Nadu, Andhra, Punjab, West Bengal and Delhi are reporting more than 30 deaths. Among tests per million, while the India average is 651 tests, if we look at this place, Madhya Pradesh is only test 244, Rajasthan 351, West Bengal 458, Himachal 507, Meghalaya 582, UP 668. India average is 651. So why these states are testing less is not understood. Look at the daily average growth. Highest growth is in Chhattisgarh, Himachal Pradesh, Chandigarh, Uttarakhand, Meghalaya, Punjab, Kerala, Jammu Kashmir, Haryana, Arunachal Pradesh, Madhya Pradesh, Odisha, Tripura, Goa, Jharkhand, Pondicherry, Maharashtra, and Uttar Pradesh. And we reach Karnataka, which is 1.9%, which is the average of 7-day daily growth in India. So these are the states, quite a good number. If you look at the number, Maharashtra is top in terms of deaths and confirmed cases, and also Maharashtra is having daily growth rate, which is high. A good data in terms of average growth rate in active cases in the last 7 days, though if you look at this is lockdown 1, this is lockdown 2, this is lockdown 3, this is lockdown 4, and this is post lockdown from May 28. If you look at the figure, we were going up and then going up and down, up and down, up and down, and we were going down. But suddenly in August, 3rd week, we started going up again. And now we are going up and down, and now started going down. Average growth rate has come down to 0.9. This is pan-India, but that is not the truth all over the country. So India did only 8.8 lakh COVID-19 tests yesterday, compared to 11.7 lakh of September 2, which is 25% less tests on a regular weekday. Surprising. At the average test positivity rate of 8.9%, if we did the same 11.7 lakh tests, we would have found more than 1,04,000 cases. Instead, India reported 93,000 cases. So, is it the final strategy for a peak that we do not test? That's not a wise strategy. We need to keep on testing till we get 5% positivity rate. This is not the correct strategy. If you look at the reduction in daily COVID-19 tests on September 18, which was yesterday, Meghalaya, minus 72%, Tripura, Sikkim, Karnataka, minus 20%. Can you imagine? Madhya Pradesh, Gujarat, and Jharkhand are reporting less tests. India averages 12.4% reduction. Bihar minus 12%, Maharashtra 10%, Odisha 7%, Punjab 5%, Rajasthan 5%, Andhra, Rajasthan, and Goa are reporting less number of tests, which is not a wise strategy. Now we see where from the new cases are coming. So what we see in general, peaks, plateaus, and second peaks. Do you see anything else amongst all the states in India? Karnataka, Odisha, Gujarat, Maharashtra, Uttar Pradesh, Telangana state, Kerala, Andhra Pradesh, Delhi, Bihar, Rajasthan, Tamil Nadu, West Bengal, Assam, and Haryana. Do you see any downfall or down slope? No, we only see peaks, plateaus, and second peaks. So you can imagine the condition all across the country. Now we go to the another graph where we have shown Other states, Madhya Pradesh, Jammu Kashmir, Andhra Pradesh, Lakshadweep, Punjab, Chhattisgarh, Jharkhand, and all across. Do you see any downfall? Any of the states? No, we do not see. We only see peaks, plateaus, and second peaks. That is the reality. And this is new confirmed cases, moving average for 7 days, last 7 days. Let's go further. Ratio of positive cases to overall tested percentage for states less than 2 lakh tests. So what do you see? Do you see less than 5% positivity rate? No. We are seeing 20% in Pondicherry, Chhattisgarh, more than 16%. Nagaland, more than 8%. So most of the states are not reporting more than 5% or 5% or less. This is for ratio of positive cases to overall tested as percentage for states more than 2 lakh tests. So what do you see? You see Maharashtra is still reporting 20% positivity. Out of 5, 1 is positive. They need to scale up their testing a lot. Andhra Pradesh, 12 to 16% positive. Tamil Nadu, more than 7.5%. Karnataka, more than 15%. UP is approaching 5. Delhi is approaching 9. West Bengal is approaching now 8%. Odisha again has gone beyond 5. The red line is the benchmark, 5%. Bihar is going down. So what you see, we need to scale up testing urgently, immediately, and on a war footing. Now let us see case fatality rate changing with time. Though CFR is falling at all India level in most of the states, but it is rising in some states and UTs. This is the cost of greatest concern and deserving immediate attention, like Punjab. Punjab is over here, 3%. Kerala is here, again rising. Why should it rise? Assam is over here, it is rising. Pondicherry is still rising. Why? Not understood. Ladakh, Goa, Sikkim, Himachal, and okay, so number of states are showing increasing case fatality rate. They need to attend to the clinical management protocol, and they need to attend to oxygen supply. They need to attend to quality of intensive care units treatment protocols. This is case fatality ratio across states with population less than 10 million. Pondicherry you are seeing, Ladakh you are seeing, Goa you are seeing here. Tripura again you are seeing up, Sikkim is going up. This is not, Manipur also going up. They're not understood why the case fatality rate, though it was low earlier, why it is going up. Now we shall take up 3 typical states, Punjab, Maharashtra, and Bihar. If you look at the trend, infection is seeing new surge with more than 2,000 cases in Punjab. Testing record is worsening with test positivity rate of 5.87% and rising. This is the rise. July, August, and September. Death rate is 3%, which is highest in the country. So Punjab needs to attend to testing, treatment protocol very urgently, isolation very urgently. Second is Maharashtra. Look at the graph of new confirmed cases moving average 7 days. Infection continues to grow unabated, more than 22,000 daily new cases. Poor testing record continues, might worsen as test positivity rate is rising beyond 20%. This is the graph, more than 20%. If you look at this is 20% line, it is again going 20% and above. Death rate is 2.5% against all India 1.6%. A very serious situation in Maharashtra is currently there. Look at Bihar, a sign of positivity. Bihar peaked sometime in first week of August, a month back. Impressive testing record with 3.6% test positivity rate. Very good. Death rate is only 0.5%, while all India is 1.6%. This may surprise anybody, but this is the truth and this is the fact for Bihar. Really commendable work done in Bihar in containing. Now they have to only ensure the second peak does not come, or if comes, then that is lower than the first peak. Real compliments to Bihar Public Health Administration. So with this, I conclude and we go on for our regular
Thank you, Dr. Rajiv, sir.
talk. Thank you so much.
Yeah, thank you, Dr. Rajiv, sir. Dr. Rajiv, sir, as you have rightly told that we are in a critical situation, the numbers are rising, and seeing the number of tests which have been conducted today on a working day especially, it's not a right strategy. We need to test more in order to bring our positivity to this.
They should start.
Yeah. So Dr. Gajen Kumar sir has joined again because his audio was not audible. So Dr. Gajen sir, can you just address the participants, sir, and welcome, give the welcome.
Good evening, everyone. And I welcome all the participants to this 26th series of our webinar. And Dr. Rajiv has given a very good presentation and all the details. Another speaker, Dr. Rayaz, is a hematologist, and he shall be talking about severe aplastic anemia, its management and details about that. Before I hand over to Sandeep, though normally we were not discussing things on the presentation of Dr. Rajiv, but very pertinent question has come to my mind. And the point is, what is the quality of test? Because see, some of the states, though the number of tests has gone up, but every test they are reporting negative. And very unfortunately, I had a video recording in which one of the DM in a district is thrashing the CMO of the district that, Dr. Sahab, I don't want to listen anything, and why so many cases are coming positive in your district. And I am answerable to the administration. You make sure that your cases do not come positive. If this is the scenario, I very much doubt that we will be able to ever win this battle. Dr. Rajiv, any comments on that? Quality of the tests, reporting, quality of the deaths, both are very important. If people start taking samples, putting it into the dustbin and giving the negative reports on the instructions of some DMs or some other body administration, then things are pathetic, I tell you. And this is what is happening.
Doctor,
yes, very rightly said. I think that is an issue, and that is an issue which needs attention. And if you see, in fact, this is not the only issue. Why case tests are reported less from a district where test positivity rate is 20%? This is not understood. Why Maharashtra completely is not reading the figures on the ground? Is there no public health administration? There is no general administration. Why it is coming still as 22%? It cannot be understood. What is so different in Maharashtra that they are having test positivity rate of 20% and still not testing enough? You cannot really continue having this kind of strategy on the ground in Maharashtra state. If you look at Punjab, why should it happen that their tests should go down? There is no shortage of tests. There is no shortage of testing capacity. The last issue of the district administration putting pressure, I think that is known to the higher administration across the country, across the state and the central government. And in fact, if you would have seen only yesterday, a central team has been sent to Jammu. Central teams are being sent to Maharashtra as well as Punjab. So there is a continuous watch on these figures. And also sufficient pressure is being made on the state administration to tighten up district administration, and not only district administration, it is the block administration where they have to ensure that coordination occurs in terms of supply chain, in not only supply chain, but actual placement of services on the ground in terms of isolation of positive cases, in terms of treatment protocols. And that is why you must have seen in Maharashtra the lack of supply of oxygen. Pan India, there is no lack of supply of oxygen, but medical oxygen supply in Maharashtra was not understood. Why sufficient logistics management could not be made, with the result that medical oxygen supply is not sufficient in Maharashtra only.
So,
Pan
sir,
India, we have 1,000 metric kiloton extra production in our country.
Dr. Rajiv, sir, we will discuss the whole situation after the guest speaker's address. So, because there are lot of things to be discussed about the COVID pandemic, and lot of administrative and other issues are there. We are under pressure. Administration is also under pressure. Everyone wants to show a goody figure. Even the district administration and state administration, everyone wants their number should be low, but the strategy should be as per the central government guidelines. So, Dr. Rayaz, sir, let me introduce you to everyone. We are an association of occupational health physicians, public health physicians, industrial physicians from different organizations, government organizations, and private corporates. So we are all joined from across India. And Dr. Rayaz, this is the 26th issue in this COVID pandemic, the new norm which we have started just to connect ourselves with every one of us, our dear members and our seniors, and we can discuss various issues like pertinent issues which Dr. Gajendra has raised or Dr. Rajiv is deliberating, and we'll be discussing all these issues after your address, because every week we try to listen from different faculty on a different topic, because amid COVID, we need to take care of our non-COVID patients also. That is a very important issue, and especially this aplastic anemia. It is a hematological issue, and you know that COVID-19 is also related very much to the hematological problems. And once this immunity is disturbed, this your this inflammatory markers, they are raised, and there is cytokine storm, then lot of thromboembolic phenomena occurs in our body, and mainly our hematology is affected, and it leads to a lot of catastrophes. So, Dr. Rayaz, sir, I welcome you, and before you can start your presentation, I would like to introduce you to the participants. Dr. Rayaz Ahmed is Senior Consultant of Hemato-Oncology and Bone Marrow Transplant from Rajiv Gandhi Cancer Institute, New Delhi. And today the topic of deliberation is diagnosis and management of severe aplastic anemia. Dr. Ahmed has been trained in CMC Vellore and has a special interest in stem cell transplant and bone marrow transplant. He is having more than 10 years of experience in stem cell transplant, including allogenic, autologous, then matched unrelated donor, and haplo stem cell transplant. He received training and fellowship in bone marrow transplant from CMC Vellore, and he is ex-associate professor of CMC Vellore. Professional journey, to his credit, is he is credited with the start of multiple pioneer works in the field of hemato-oncology, organized much training in this field at the global level. He has been awarded with University Gold Medal in MD Pathology in 2003 from Shivaji University, Kolhapur, Maharashtra. Worked as Associate Professor in Department of Hematology, CMC Vellore, and performed 300 plus stem cell transplant at Rajiv Gandhi Cancer Institute. Worked as Principal Investigator in many medical oncological hematological trials in 2010. And he did his DM in hemato-oncology from CMC Vellore, MD from Shivaji University, Kolhapur, Maharashtra. He did MBBS from Pandit Ravi Shankar University, Raipur in 1999. So, Dr. Rayaz, sir, you can share your screen, and you can start your presentation.
Thank you, sir. Thank you, Dr. Sharma, and thank you, Dr. Jain, for inviting me to this talk. And thank you for your giving me this opportunity to talk to you. This is my first time I'm speaking to the Bahadurgarh forum. I have been told to speak on severe aplastic anemia, so I'll keep it as simple as possible. So the next, can you come to the next slides? Yeah. So before I start, there is a simple case as we come day to day in our clinical practice, and mostly the physicians will be seeing 51-year-old lady comes with increased gum bleeding and while brushing her teeth in the morning since last 4 weeks, and she has difficulty in climbing stairs in her home. She had one syncopal episode 1 week previously. So that was the relevant history. And another is she's obese, she's got GERD, she has got hyperlipidemia. Family history of hypertension, diabetes, and heart diseases are there. There's no other inherited disorders of hematological disorders or cancer. Examination, she's pale, pulse, little tachycardia is there, BP is normal, weight 70 kg, height 45 centimeters. On examination, she's got pedicle rashes over trunk and lower extremities. Lymph nodes are not palpable and liver spleen not palpable. So this is one typical case scenario which everyone comes across once in a while in another patient. Or there can be another cases where you see a CBC report of a person who has got low hemoglobin, low TLC count, and low platelet count. So sometimes we jump to a conclusion that, okay, low hemoglobin, low TLC count, and low platelet count is aplastic anemia. So actually that pancytopenia is not synonymous with aplastic anemia. Pancytopenia can be many other reasons. So pancytopenia, we have like either it is a production problem that the blood is being produced in the bone marrow, whether that bone marrow site is involved, or it is a peripheral destruction problem, like the bone marrow is producing adequately, but it is being destroyed peripherally. So I'll give you examples. Like if it is a production problem or some bone marrow infiltration problem is there. So you can have like some drugs are causing like, or immune phenomena is there. We've got hypoplastic marrow. You have got some leukemias are there, which is infiltrating and it's not allowing bone marrow to function. Then you have got bone marrow is production is normal, but you have got sepsis or immune phenomena, which you got hypersplenism. The blood cells are being formed, but it is getting absorbed in different means in the spleen so we commonly find pancytopenia with splenomegaly, and mostly it comes out to be hypersplenism. Or in severe sepsis, you can find pancytopenia. So pancytopenia to the audience today is we should at end of the day we should not be saying, okay, pancytopenia is not equal to aplastic anemia. Pancytopenia means further investigation. It can be very well be chronic liver disease with hypersplenism, or it can be megaloblastic anemia, simple megaloblastic anemia, which can cause pancytopenia. And in sometimes you can find that bone marrow is not producing cells, and then can lead to what you come at a further diagnosis of aplastic anemia. So these type of cases we frequently encounter. So next slide, please. So aplastic anemia, it's not a disease of West. Actually, most commonly it affects in the Southeast Asian countries. India is one of them. The lower middle class, lower economic strata diseases, it's more commonly reported from Singapore, Thailand. India is one of the major, one of the most commonly in one of the countries which has got aplastic anemia in bulk. You can see lot and lots of than what we see in the Western countries. So, but the data accumulation, the data of Western world, as we say, they are more systematic in the Western, and we get most of the literature from there. So in the incidence in the Western countries, you have got 2 cases per million. In East Asia, the incidence is 2 to 3 times higher than in the Western countries. And in India, it is estimated to be 6.8 per million population. It affected both age. It can affect any, it can affect both sexes. It can affect any age. And aplastic anemia can be inherited or acquired. So here in this slide discussions, we are keeping our discussion to the acquired. Next slide, please. Inherited is mainly you come in form of dyskeratosis congenita, or it can form Fanconi's anemia. These are the few cases which what the pediatric population will pediatrician will face in day-to-day practice. But in idiopathic, it can affect both children and adults. So we have seen that it is affecting both sexes. Although aplastic anemia may occur in all age group, there is a biphasic distribution. Yes, it commonly occurs between 10 to 25 years of age. We see more commons, and then older than 60 years of age. But all ages, all decades of life, a risk of aplastic anemia is there. Aplastic anemia is associated with premature mortality, not because of we don't have much treatment available, and the treatment which is available is quite costly. The treatment of aplastic anemia will come and see how it is different, like not routinely the medicines which are available. The supportive care is very cumbersome. The patient gets infected very often. Okay, so in children, majority are diagnosed within less than 16 years of age. More than 25% have genetic origin. So any person, any pediatric child, any pediatrician who is seeing a child of aplastic anemia, and if they have diagnosed, they must rule out its genetic cause. Like stress cytogenetics is being sent to rule out Fanconi's anemia. You can always rule for having the patient having pulmonary fibrosis, or if any associated hyperpigmentation, vitiligo, capsulate spots, all these things which help in diagnosis. Okay, this can be inherited, especially in the pediatric age group. The importance is they are treated little different from inherited aplastic anemia. There is little difference between the acquired aplastic anemia. So next slide, please. Okay, so before we come, there are different reasons with the different causes of aplastic anemia which has been implicated. One of the older literatures is chloramphenicol injection by the prescription by the physicians of chloramphenicol has caused aplastic anemia. Penicillamine, anticonvulsants like phenytoin, carbamazepine, antithyroid like carmazole and thiocel, chemotherapy drugs can cause aplastic bone marrow aplasia. Benzene and pesticides have been implicated. Pregnancy, yes, we do find pregnant female having aplastic, but this is usually autoimmune phenomena. Post-pregnancy, generally they recover their counts. Autoimmune destruction is mainly because of dysregulated T cells within the body, which it destructs its own bone marrow and leading to aplastic anemia. Next slide, please. Now, this is the usual presentation. Patient generally, initially, they try to ignore their pedicle spots. They try to ignore their gum bleedings when it's quite florid when they visit the physicians. And when we do the initial investigations, we will have pallor, we will have petechial and petechial ecchymosis in different parts of the body. Fatigue will be one of the symptoms. Skin, you will find all this gingival bleeding, epistaxis, easy bruising. And when you do a CBC, typically you will find hemoglobin low, TLC in the range of 100, 200, 500. Platelet counts usually less than 10,000. Next slide, please. So once we face this type of patients, when we have a pancytopenia and patient is symptomatic for bleeding, or patient with low neutrophil count, they are prone for more infections. You have got febrile neutropenia. They are generally the patient who requires urgent attentions. They require IV antibiotics. They require replacement of blood and platelets as soon as possible. Platelet count of less than 30,000 is highly suggestive of that patient can bleed into the brain anytime. So generally more than 30,000 is a safe limit of for any person not to bleed. If any patient is going for any surgical procedure, we generally require more than 1 lakh. But above 30,000, generally patient is able to live. Less than 30,000, its have risk of bleeding increases tenfolds. Now, when we see this type of picture, when a hemoglobin of 6.8, WBC count of 800, absolute neutrophil count of 300, and platelet count of 7,000, means something is going wrong. The first thing we should be looking after doing the careful examination, there is no hepatosplenomegaly or lymphadenopathy. If all these presence are there, generally it rules out aplastic anemia. It goes more in favor of malignancy. Or if you have got only splenomegaly and pancytopenia, you must rule out chronic liver disease. Or if you have got lymph nodes, you can rheumatoid arthritis. type of having arthritis problem. So this thing, but always remember pancytopenia, you should always make a point to do a bone marrow. Now in bone marrow, it's two things. It's not only aspirate, it's the biopsy also is very important. Aspirate, you should see the cellularity generally with age. Like if the cellularity of age, it's pertinent to some age. Like if I do a bone marrow of 10-year-old child, 90% will be cellular, 10% will be fatty. So that will be normal for age. But if I do a bone marrow of 50-year-old, it will be 50% cellular, 50% fatty. So that is normal. But if I get 50% cellularity of a marrow in a 10-year child, it will be labeled as hypocellular marrow. Now, bone marrow aspirate will show marked reduced production of RBC forming cells, that is erythroids, will be reduced platelet forming cells, that is megakaryocytes, and the myeloid cells, with the prominence of mast cells and lymphocytes. Some erythroid precursors you can see in the bone marrow biopsy. So if we have a bone marrow aspirate and biopsy slides, or a report if we share 10% cellularity, and if you have seen prominence of mast cell, lymphocytosis, mild erythroid, and absence of all other cell forming elements, you can easily make a diagnosis of aplastic anemia. Once the diagnosis of aplastic anemia, it's an emergency condition. Aplastic anemia is not cancer, but it behaves as like a cancer. If we treat the patient before it gets number of transfusions, their outcome is different. Data is there. If you start a diagnosis, suppose a patient is severe aplastic anemia, and if you have done transplant, who has received less than 20 transfusions, their outcome is much better than those patients who have been on transfusion therapy for 2 to 3 months and then they have gone for transplant. Their outcome decreases. So if it is less than 20, it can be in as high as 80% of the people will get better. They can get cured for transplant. If it is more than 20 transfusions, 1 month period of time, and if they go for transplant, the success rate comes down to as low as 50 to 60%. Next slide, please. So what all the additional investigation will you perform in your routine practice? Next slide, please. So when you're suspecting aplastic anemia based on clinical examination and the history given by the patient, you do is full CBC count. It's not only the hemoglobin or WBC count or the platelets, full CBC count with peripheral smear examination and bone marrow examination. Now, CBC is a very important test in all hematological disorders. You see what is the hemoglobin, what is the TLC count, what are the differentials, what is the platelet count. If there is, and the peripheral smear asked to look for regular things, like if you are finding any malaria parasite or not. Even malaria, sometimes severe malaria can cause this pancytopenia. If you have got hypersegmented neutrophils, 5 segments of neutrophils, if you read that, mostly you can be a case of megaloblastic anemia. We had commonly in India a lot of megaloblastic anemia who get infected and they can present as aplastic anemia. So never ever make a diagnosis of aplastic anemia when their patient is sick. Do check their vitamin B12 folate levels. Generally, when patient, by the time they have come us, they have received a loads of vitamin B12 and folate test. But sometimes the patient comes to us in an infected state, their vitamin B12 is low. Sometimes simple administration of B12 and folate will correct their bone marrow. You correct their sepsis, correct their B12, and you can say full recovery. If it happens that in spite of that, if your bone marrow is aplastic, WBC has and TLC, hemoglobin, TLC, platelet count has not recovered, then a diagnosis of aplastic anemia is made. Reticulocyte count will be low. Do ask for reticulocyte count. It's the marker of red cell production. Blood film examination, as I already told. HbF percentage, fetal hemoglobin will go up as you find the low hemoglobin, not routinely done, but yes, if it is facilities available, you can ask for it. Now, pediatric patients can have this stress cytogenetics. If we can do this stress cytogenetics on the peripheral blood. If the stress cytogenetic comes in a diagnosed case of aplastic anemia, the diagnosis changes to Fanconi's, but generally they will have some morphological presentation which suggests that it can be. Sometimes you can have a patient who doesn't show the morphology of physical morphological, like high arch palate, low set ears, these things may not be, or cephalosports or vitiligo, which may not be present. But on the stress cytogenetics, you can find it is positive and the treatment is different. In sometimes PNH cause paroxysmal nocturnal hemoglobinuria can present as pancytopenia. Sometimes doing a flow cytometry can solve the cleanse the diagnosis, and the treatment of PNH is totally different. Now, vitamin B12 folate levels, I have already told. Liver function test, if you can do, especially if you have got hepatitis secondary to hepatitis A, hepatitis B, hepatitis C. Sometimes you have the hepatitis associated aplastic anemia is there. If you treat this with, they generally if they have not resolved aplastic anemia by the resolution of hepatitis, they generally respond very well to immunosuppressive therapy. We should check all this hepatitis A, B, C, Epstein-Barr virus, CMV, HIV, parvovirus. These all can cause cytopenias. Parvovirus is mainly implicated in pure red cell aplasia, but rarely it can cause pancytopenia also. ANA test, dsDNA can cause pancytopenia in form of this. As for SLE, the diagnosis can be SLE, but the presentation can. So you have to rule out all these things. Chest X-ray should be done, abdominal ultrasound and echogram, especially for the pediatric patient, where you can find horseshoe-shaped kidney, and you can have the findings that, okay, this is not only aplastic anemia, this is also a case of Fanconi's anemia. Next slide, please. Now, diagnosis of aplastic anemia is an idiopathic aplastic anemia is diagnosis of exclusion, and no single test reliably diagnose idiopathic acquired aplastic anemia. Once you have done all the above tests in the peripheral blood, you do a marrow. And once you do a marrow, you should look for cellularity. You should look for the production, the cells which produce RBC, that is erythroids, myeloids, and megakaryocytes, which forms WBC and platelets, and see what is their percentages. Generally, they are absent. Once you have this, confirm the diagnosis, you exclude other causes of pancytopenia and hypocellular marrow. See the drug history, commonly patient on this anticonvulsant. Patient can be on neomercazole and they can present with pancytopenia and hypocellular marrow. So we should not always, like pancytopenia and hypocellular marrow, jump to a conclusion of aplastic anemia. Take a routine, detailed history, which drugs they are taking, how long they are taking, have they been exposed to any other newer drugs which have they recently started. We need to ask again and again. Document the presence of PNH and the cytogenetic loop. It makes a lot of difference what exactly we are treating. Next slide, please. Now, this is the aplastic anemia is classified by very severe, severe, and non-severe aplastic anemia. Now I'm going a little bit more specific into idiopathic aplastic anemia. This is the classification. Now, presentation of all this aplastic anemia, severe, non-severe, or very severe, is little different, and their management is different. Non-severe aplastic anemia is when the absolute neutrophil count is more than 500. So even 500 WBC neutrophil count, not WBC count. If the TLC count is 1000 and ANC is 500, it's a non-severe aplastic anemia. These guys don't require transplant. They will do well with immunosuppression, immunosuppressive therapy. If they don't have ADGAM based therapies, if it's too costly, giving cyclosporine, simple cyclosporine can help these patients to attain a good quality of life. Now, this recommendation is by British Society of Hematology. Like non-severe, you have to do a marrow, hypocellular bone marrow with peripheral values. It's like this bone marrow cellularity less than 25% of the normal, and neutrophil count less than 500 per cubic mm, platelet count less than 20,000 per cubic mm, and reticulocyte count, absolute reticulocyte less than 200. You can have this. You say when you are meeting all these criteria, it is severe aplastic anemia. All the criteria, but if the ANC is less than 200, it is very severe aplastic anemia. And suppose if the ANC is above 500, these are not meeting any criteria of this, then it is non-severe aplastic anemia. We see all this in equal category, but the clinical presentation in emergency, generally you will find very severe and severe. Non-severe can roam around for many days from one clinic to another clinic, taking multivitamins, and finds they have their transfusion when over a period of time, when they progress and they have been transfused regularly, then they will come to the notice. Next slide, please. Sure. Now, this patient is, we told that this all inherited bone marrow failure syndromes was negative, like stress cytogenetics was negative. Generally, we don't test above 50 years of age, but in this stage, it was tested. In this patient, it was tested. It was negative, and this lab parameter CBC was showing 6.8 hemoglobin, WBC count of 800, absolute neutrophil count is 300, and the reticulocyte count is 70, and the platelet count is 7,000. Now, all this fits into the severe aplastic anemia. So the final diagnosis will be acquired severe aplastic anemia. If the ANC would have been less than 200 and all the criteria is there, then we would have labeled it as very severe aplastic anemia. Next slide, please. Now, this is a treatment algorithm given by the British Society of Hematology. So first is the age of the patient, and then you see what's the age group they belong to. Now, if it is less than 35 years of age, if they have an HLA identical sibling, if they have a sibling in which the HLA is matching, generally 25% of the patient will have their HLA 100% matching with their sibling. If they have that, we should immediately go ahead with the case bone marrow transplant as early as possible. Like if I told you that if you are keeping the patient on transfusion of blood and platelets, if it is more than 20 transfusions, the outcome of doing transplant after that is totally different than what we see whom we transplant less than 5. So it can be as high as 80% to 85% of the patient will be getting cured for life if they are getting early transplant. And if it is done after 20 transfusions, it will be as low as 50%. Sometimes we'll feel sepsis is the main cause of the death in these type of cases. Now, 35 to 50 years of age, when it's a borderline, we don't have much choices. We will go do the HLA matching. If it is matched, we give them an option that it's a one-time treatment. We still prefer in India to go ahead with a transplant. But if the patient is not willing, is scared, and they have got any comorbidities, you can go ahead and give the ADGAM injection. So this is immunosuppressive therapy over a 4 to 5 days period, and little costly. These injections, it's given on based on the body weight, and they cost, if a 50 kg it can cost up to 6 to 7 lakhs in 4-5 days. But the response rate will be quite good. 50% of these patients generally respond to this treatment and can have a good remission-free period of 5 to 10 years. More than 50 years of age, no transplant. In India, yes, high risk, they belong to high risk category. Finances are a tough one. We discuss with the patient. We do generally up to 60 years of age. Generally, we give them an option, but telling that this is a very high risk. Some patient, we do take them for transplant and they do well. 40-50% of the patient. Yes, but according to the Western guideline, they generally don't do above 35-40 years of age. They generally will prefer ATG. The difference in them treating with ATG and we treating as ATG is they have a supporting system. They have a very good hospitals. They will have good staff. The transfusion of blood platelets is not that difficult here. Getting transfusion, a patient of aplastic anemia will be requiring 1 unit per week. Platelets almost alternate day to or once in 2 days. Arranging this for a family in India is very tough. And in the meantime, the patients get infected, they admit live antibiotics. The cost for care times exceeds the cost of transplant. And most in India, most of the people belong to lowest socioeconomic strata. Mostly they will not be able. So most of the people will be going on only on cyclosporine and danazole with dismal outcome. Next slide, please. So these are the based on these guidelines in this patient, what will be, this is a 51-year-old lady. So what should be our treatment approach, whether we should give, HS is the horse ATG. Actually, this ATG protein has been either you can acquire from rabbit and horse. Most commonly we use horse, and CSA is cyclosporine is another immunosuppressive drug, or horse ATG plus cyclosporine, all newer drug which is called L-Trombopag, Revolade. This is available in India, L-Trombopag. So whether this combination or transplant. Now, as I told you, according to the guideline, this patient should be given transplant. Now, but we should, it's up to the hematologist who are treating and the patient who is seeing, if they have got an HLA matched sibling, and very severe aplastic anemia, I'll generally counsel them to go for transplant because it's a one-time treatment. And if they respond to the treatment, they will 60-70% chance they will have a normal life after that. But if there is no HLA matching, the patient is sick, patient is not willing, lot of comorbidities present, generally we'll go with ATG. Now, initial data was there to give ATG plus cyclosporine. Generally, this is 1 month treatment, 4-5 days of ATG and cyclosporine. We start, follow up the patient. Generally, you require 3 to 4 months before the patient respond to the treatment. If they don't respond within the 4 months, generally the patient is labeled as refractory or non-responsive to ATG generally. So during this time, they are as like any other pancytopenic patient, they will require transfusion again and again. The time to response to this horse ATG and cyclosporine is maximum, they will respond up to 120 days. If they don't respond, we say they are refractory. They need a repeat doses of these injections. So addition of eltrampovec has made things little bit better. So if the response rate of in adult patient horse ATG and cyclosporine, if it was in the range of 60-70%, eltrampovec has increased another 15-20% to that. So it is as good as transplant data. So if the patient who are sick and has been given horse ATG with cyclosporine and eltrampovec, generally cyclosporine we continue for 6 months to 1 year, eltrampovec for 3 months. The data will be in the range of 100 patients being treated all this drug combination over a period of time. They will be, you say 70-75 people. So my humble request to the audience is that once you find an aplastic anemia, and you should counsel them for treatment, either transplant or ADGAM based therapy. Although it is little costly, but if they have gone through all this, they can generally lead a good, they can have a good normal quality of life. They can go back to their work. They can do all the therapy. There is not much side effect except for the this sepsis. If once they respond, their neutrophil recovery is there. When the RBC production restarts and the platelets is above 1 lakh, they generally lead a normal life. Next slide, please. Now, treatment option in severe aplastic anemia. Next. So, as I told, transplant can cure almost 90% of the patient, but this here is the catch. Catch is they should be referred to a transplant center as early as possible. First point. Second point, they should have a HLA match sibling. Like there should be, out of every 4 patient of hematological disorder, means aplastic anemia who's coming to us for transplant, only 1 family will have a HLA match sibling. So what the rest 3 will do? Generally, we have to get this stem cell from outside registry, which is again costly. So in sibling donor transplant, only 1 person is having. So this is a limitation of this doing transplant. And other limitation is the referral, early referral. The patient generally takes time. The finances is not like every patient roams around with the money that they can, they have all the money in the world and they will do. But if a family is having affording, families understands the score, if we can shift the patient as early as possible to a transplant center who can do a transplant, the response rate is totally different. They will have almost normal life. So age, again, less than 35 years of age, you can counsel the family for going for transplant. The better it's if it is less than 35 years age. In India, we do up to 60 years of age, but yes, the outcomes are not as good as 80-90%, but in the range of 60%. Now, you can see according to on the right side of the screen, there is a according to the age. This is the from the European data. If you have done transplant of 1 to 20 years of age, their long treatment free means disease free interval is in the range of 86% of the patient have responded. And if 21 to 40, you can see 76% of the patient. More than 40, you can see 55%. You can reduce 10% in all this age group. If we have an Indian data, we have an Indian stem cell registry, almost less than 10%. It's only just because of the sepsis and the late arrival of patients to the transplant center. Second is the late arrangement of funds. These are the practical point. I think so. It's not only in the hematological disorders or cancer management. I think so. All the diseases, faces the same problem when we have going higher end treatment, either can be kidney transplant or liver transplant or any kidney related problem, liver related problem. The early referral or the early starting of the treatment is the problem. Next slide, please. Now, those who can go for transplant, I said those who have a HLMS sibling, they have all the finances in the world, they understand the score, transplant done, life is happy. Only 10% of the patient, generally 10 to 20% of the patient will fail transplant, or they will not respond to the transplant, or they will relapse after transplant. But what to those patients who constitute a major chunk who cannot go for transplant? So what will happen to them? Generally immunosuppressive therapy. So as I told you, 50 to 70% of the patient will recover and they lead a normal life. Age is the again best indicator. Those who are given immunosuppressive therapy, less than 20 years of age, they will have a response rate of as good as 80%. And those who are above 40 years, response will be as in the low as 50%. Next slide, please. Next, if you can press the button. Okay, so this was there from 1990s to 2010 to 2015. There was not much difference in the management of aplastic anemia. Now, lately, a new drug has come, which is called Altrambopag. And this, when data is when the ATG was combined with cyclosporine with Altrambopag, it gained another 10-15%. Next slide, please. Next slide. Yes. So next slide. This is all those who have at least 1/3 of the patient generally doesn't respond. So when we added Altrambopag to this, the probability of recovery increased. Next slide, please. This is the in vitro data, how the hematopoietic stem cells are not much to, I will skip these slides. Next slide. Next slide. So what we did is Altrambopag we added to the first line of treatment, and what within 3 months you can see patient respond, 99% of the patient responded. Only thing is the response should be sustained for over a period of time. Generally, we give 3 months of Altrambopag into the Indian subcontinent because of patient with on this Altrambopag have a high risk that they can have dysplasia. They generally develop dysplastic features. It's another disorder. So 3 months is optimum. Continue cyclosporine for 6 months, immunosuppressive therapy, initial 4-5 days. And these patients, generally 50 to 70% of the patient respond. They can have 1/3 of the patient will again relapse. But out of this 1/3 patient, we say 30% of the patient, 10% of the patient will again respond to immunosuppressive therapy if they have not changed to dysplasia. Next slide, please. So this is another study from National Institute of Hematology, USA, Altrambopag. Again, I've told you this is almost in the range of 90% while adding. Next slide, please. So transfusion independence, these are all showing this Altrambopag safety and efficacy. Next slide, please. Sure. Now, this is the different. Now, every people can give this ATG. There are different protocols available: 4 days infusion, 5-day infusion, 10 days infusion, cyclosporine and Altrambopag. And you start from the day one. These hematological disorders are common and the treatment is little costly. So Altrambopag, cyclosporine, ATG. Suppose a patient, a poor patient who cannot afford this much amount, even giving them cyclosporine, you can salvage 15% of the patient. Although 15% of the patient is too low, but at least it's better than zero. Next slide, please. What is the importance of cyclosporine? Next slide, please. So cyclosporine, as I told, cyclosporine is, if I take a all over data of India, how many patients of aplastic anemia has been treated in last 10 years, and what was the most common modality, which was the most common drug used to treat aplastic anemia? It will be cyclosporine. Most of the government hospitals will give cyclosporine because patients cannot afford. Even cyclosporine will be in the range of monthly treatment will be in the range of 10 to 15,000 per month, and they require for almost a year. And it's only the cyclosporine cost. The cost of transfusion, cost of infections is add-on. So sometimes majority of the patient will just go away with cyclosporine. They cannot even afford ATG. Transplant is a few select patients. Next slide, please. So the case continued. The patient was put on cyclosporine and it was given ATG and cyclosporine was continued for 6 months to 2 years, and you can see the patient's 6-month result was as good as normal. There was no cytogenetic abnormality detected at 6 months, 1 year, and 2 years. And the quality of life there was fantastic. The patient improved and patient was very happy. Next slides. In the summary, continued supportive care is essential for the patient of aplastic anemia. Supportive care includes blood transfusion, platelet transfusion, management of infections like antibacterial, antibiotics, antifungals. It is important to achieve robust hematological response, complete response among the patient with severe aplastic anemia to improve long-term outcomes like overall survival. Combination of immunosuppressive therapy over thrombopoietic receptor agonist represent first-line treatment options for the patient of severe aplastic anemia not eligible for transplant. Now, this is ATG with cyclosporine with Revolade. And the addition of Altrambopog and day one will really change, at least it will give 10 to 15% better response that only giving ATG and cyclosporine. But that doesn't mean that you cannot give cyclosporine alone. If you have a patient who cannot afford, please, once the diagnosis has been made, even giving cyclosporine is going to save 10 to 15% of the patient. The overall safety profile of Altrambopag at the doses is quite good. And my request to the house is, once you diagnose aplastic anemia, convince them for early treatment. I'm not saying transplant, early treatment, so that they, at least we were able to save few patients from this deadly disease. Next slide, please. Thank you. Thank you for patients listening. If any questions, will be happy to take that.
Yeah, thank you, Dr. Rayaz. So,
thank you, sir. Thank you.
Yes, aplastic anemia is a very severe disease, and it is very important for every one of us to diagnose it. Timely diagnosis is very important. As you have rightly mentioned, that aplastic anemia can be acquired or it can be inherited also. So genetic. So like we are all working in industries, and you, as you told that this pesticides and this benzene, especially like I am working with Indian Oil Corporation, and many of our people who are working in petrochemical industries, their workers, they are exposed to all these sort of chemicals, and which can lead to aplastic anemia. So any guidance from your side for screening all these patients, or
they should have a regular CBC checkup? That should be okay. Once in 6 months, that will be okay. Means we cannot avoid that. We cannot say that, okay, you change your job or less exposure to the benzene, take full adequate preventive measures for getting ourselves exposed to benzene. And once in 6 months, the CBC will tell you which way we are going. If it is all normal, see, if it aplastic anemia has to happen, it's not like that. It is a cumulative effect. If you are exposed to that, and it will suddenly start. The only thing is, even if it starts happening, your diagnosis should be early. The early diagnosis, early treatment, you will recover fast.
okay. So we have that in periodical medical examination as per Indian.
Periodic checkup should be there. Yes, periodic checkup should be there.
We are all doing all this blood tests and other required tests. We are all doing, and we are monitoring these parameters. And I just wanted to know whether
that should be okay, sir. That should be okay.
Treatment line is also the same for both the acquired and genetic causes of aplastic anemia.
No. Acquired aplastic anemias is generally you can see in any age group, but inherited aplastic anemia will not only have this bone marrow disorders, they will have also different organs affected. These children are more prone to develop cancer over a period of time. Every cancer, oropharyngeal cancer, liver cancer over a period of time. Treating like Fanconi's anemia, they will have a presentation with pancytopenia. When we do a bone marrow, they will have this aplastic hypocellular marrow. But when we send this stress cytogenetics on their blood, it will show increased chromosomal breakage. that clinch the diagnosis of Fanconi's anemia. They can have some finger abnormality, they can have some low set ears, they can have high arched palate, they can have vitiligo spots on their body. Now, difference in that management is, while doing stem cell transplant for these patients, it is only going to correct their hematopoietic system. It's not going to correct their Fanconi's anemia other related. They are prone to cancers as good as that. But if we don't treat them, they are going to die in another 1 or 2 years. So if we treat them, at least their life will be extended for at least 4th decade, 5th decade of life. They can have other problems, but majority of the problem of inherited. Now, other problem is dyskeratosis congenita. This is another form. Again, they will have lung fibrosis to their common problems to that. They can die of lung fibrosis in their 3rd or 4th decade. But this pancytopenia, hematological, this generally present in 1st decade. So if you treat them with transplant, they can live to that life 40 years, 50 years. But generally, if we are not going to do transplant for these guys, they will die in 1st decade of their life. Okay, immunosuppressive therapy is not going to work in this inherited aplastic anemia. Inherited aplastic anemia, Fanconi's anemia, or dyskeratosis congenita. They will require either transplant or supportive care. There is nothing in between for them. And acquired aplastic anemia, which is the major chunk of this aplastic anemia, if transplant is a good modality for severe and non-severe, non-severe will do very well with immunosuppressive therapy. And even with severe aplastic anemia, those patients who doesn't have HLA matched sibling, or those who cannot afford transplant, they should be given immunosuppressive therapy. And though among those also 50% of the patient will respond and have good quality of life. Aplastic anemia, if they do not respond to this immunosuppressive therapy or not taking treatment, generally they will die within next 6 months to 1 year. It can be as fatal as 24 hours, 48 hours. They will have very low platelets, 7,000, 5,000. And even if when you transfuse them regularly, they become refractory. Like that, if you are transfusing platelets, generally the half-life of transfused platelets within the body is not more than 24 hours. So you have to transfuse them again after 24, 48 hours. Again, the platelet count will rise to the level of 30, 40,000. Again, it will drop over a period of time. 1 or 2 days. Multiple transfusions will make their body refractory. So transfusions are not going to work after some time. And they can have some icy bleed. And that generally takes their life. It's majority of the patient die of because of the bleeding, or they die of the infections. The neutrophils is very low. They are very prone to get infections from their own body, like urine gets infected, their stool gets infected, their sputum gets infected, and they catches infections from there.
Okay. Dr. Gajan Kumar sir, you have any questions?
Yes, little administrative question. What is the cost of transplant vis-a-vis this combined therapy?
Sure. In adults, I can tell you, sir, if it is, you have an HLA matched sibling, like I am a patient and my brother is matched to me. And if I'm getting a transplant in any centers that will, in my age group and normal body weight, why I'm saying all these things, according to my body weight, lot of medicines will be used, and the cost of medicines are quite depends on the body weight. So 40, 50 kgs, 60 kgs, the transplant cost will be in the range of 10 to 12 lakh rupees. First month cost. And another 4-5 lakhs will be in the follow, if there are no complications. And immunosuppressive therapy in my age group, in my 60 to 70 body weight, it will be in the range of 6 lakhs for the ATG, and Revlimid will cost you another 2.5 lakhs. Cyclosporine generally 15,000. So that is also very costly if I give all the 3 immunosuppressive standard. So the cost it's quite expensive. So it should not be taken as aplastic anemia is a diseases of the rich, only rich can take treatment. No. Whole aim is, if once you diagnose it, if it is an acquired aplastic anemia, afford them the best. If they can afford transplant, well and good. No second option, ATG, if that is also not possible, give them cyclosporine. Again, I'm telling you, cyclosporine also do wonders in 10 to 15% of the patient. Well and good if they can afford everything. But cyclosporine should be given. That is minimum they should get it.
Dr. Rajiv sir.
I must thank you, Dr. Ayad, to actually give a very comprehensive presentation, very
Thank you,
lucid
sir.
and simple.
Simple. Thank
The
you, sir.
question that is coming in my mind, and with one of my physician colleague who is treating adult aplastic anemia patients, he's asking COVID-19 with aplastic anemia. Should we continue cyclosporin or should we stop or reduce the dosage?
Wow, that's
Or
great question.
comprehensively COVID and aplastic anemia?
Sure, sir. Okay, so if the cyclosporin is not that immunosuppressive, in if it is patient is not symptomatic, like if it has come as COVID positive, asymptomatic, please continue cyclosporin. Patient is having desaturation, like in moderate, like it's getting respiratory symptoms, but can be maintained on oxygen, will not require much remdesivir or any steroids. Please continue cyclosporin. But in severe cases, patient requiring going to high flow nasal cannulation, patient oxygen saturation is dropping and require all sorts of treatment, we can safely omit cyclosporin during this condition. So asymptomatic and mild, moderate cases of COVID-19, no issues. But severe cases, yes, we should stop because we are making more prone. Infections are going to be there in the body for more number of days. We can safely stop this cyclosporin.
A second question is regarding the age at which you get, what is the predominant age, especially in the pediatric age group, that you get cases
Sure.
for transplant in your hospital, Rajiv Gandhi?
Sir, generally it's a cancer hospital and aplastic anemia is not a cancer. So a lot of people get worried, why should I be going to a Rajiv Gandhi Cancer Hospital for treatment of aplastic anemia? So no, we are hematologists actually, and we treat everything related to blood. So aplastic anemia in pediatric age group, you have a bimodal peak of presentation. It will be less than 20 years and more than 60 years. More than 60 years of age, no transplant. Generally, we also prefer giving immunosuppressive therapy. Aplastic anemia, yes, we have done quite number of cases, 20, I think so in last 3 years, 20 cases of aplastic anemia being transplanted in our center. More number of cases has been transplanted in Vellore. I think so, if I say they are transplanting 200 patients per year, you can say 50 patients will be there of aplastic anemia. 1/4 of the patient will be of aplastic anemia, and 1/4, 25% of the cases will be of acute myeloid leukemia. So these two cases will be more, and another chunk is more common. There is thalassemias. So these three generally constitutes major allogenic transplant cases. Rest is less. Leukemias will be lesser. So it reflects that how much the percentage of patients affected. Vellore is an old center. The transplant started there earlier, but now other centers, Delhi has got, actually, if you see number of transplant centers in Delhi and number of patients being transplanted in Delhi is actually more than any part of our country. Delhi will be doing almost 1,000 transplants per year, bone marrow transplant, compared to the Vellore who is doing 200 transplant. But as a hospital, Vellore still hold good. As a single hospital, it does 200 transplant. But in Delhi, if we combine all the major centers, it will be close to 1,000 transplants. So different hospitals are there. BL Kapoor is there, AIMS is there, Fortis is there, Max is there. They all are doing this transplant, and fair number of success. The cost may vary from one center to another, but almost I can say the good outcomes in every center.
Of course, our experience at least in pediatric aplastic anemia has been very good, very rewarding actually, because we see the very good follow-up in railways, and they perform very well. They perform very well. It's a real life saved.
Yes, sir. Real life saved. Yes, sir. Truly.
Thank you so much. Thank you.
Yeah.
Thank you, sir.
Other panelists, if you have any question, Dr. Tyagraj sir, Dr. Sudha madam, Dr. Kamla Fartial.
Yes, Sandeep. Thank you. Good evening.
Yes.
Thank you, doctor, for a very informative talk. I have a couple of questions. One is, you said the quality of life is good after treatment, if they're able to afford the treatment. Good in the sense, would it be normal, and what is the percentage that they can go up to? And my second question is, have you come across anybody where, not for money is finance, if they can't afford, it's a different question. Have you come across anybody not taking this seriously, like they would take a cancer and a heart attack or a stroke?
A second, can you repeat the second question? First question I got it. Second question I'm not
Yeah,
able to
second
understand.
question was, what are the response of people to a diagnosis that you make on this? Do they take it seriously that they would take a cancer, heart attack, or a
Got
stroke?
it. Yes. So ma'am, your first question was about quality of life. Yes. Quality of life, generally when the patients are diagnosed early, suppose they are on routine investigations, picked up as pancytopenia, all the other investigations are normal, they are not requiring, they are just starting, and you do a bone marrow and tell them aplastic anemia, it's very hard to believe for any Indians. If it happens to me, I will be little apprehensive. If we're educated well, they will take it little seriously, but most of our populations, they don't believe that. So even if they have got pancytopenia, low hemoglobin platelets, they will be just try to be like taking blood transfusion, platelet transfusion. They will run from one clinic to another. Even if they have done bone marrow test, they will try to get it repeated again. It's like, okay, whether let's see with the other doctor whether they are doing the same set of investigations or they are going to say something, or there are, if we say okay, cyclosporine or sometimes anabolic steroids work, that is danazol works for them. So if you give them, and the response rate is very dismal, 5% of the patient response. So they will try, okay, maybe this doctor is not knowing, maybe the other doctors know. So we see empty number of cases of aplastic anemia who will just come for diagnosis. We'll tell them all these things and they will just go to another clinic. After roaming, and once they are fully, it takes at least 1 month, 2 months period time for any majority of the public, you can say, to understand the seriousness of that. How they become serious about the disease, they will again complain. The more the number of transfusions happening to the patient, they will get serious. Okay, something is going wrong. Like platelets getting transfused once a week or twice a week, or blood getting transfused every week. They get serious. Okay, and if they get infected and they are not getting better, they get a serious infection, neutrophils are low, they get a fungal pneumonia, they are on oxygen, then that is the time when most of the public will get serious. Okay, we have got aplastic anemia, or it can, or if they have developed any hematomas, or they have developed petechiain ecchymosis, that is the time they will get the visual impression. Once they get it, that's the time serious. If they're asymptomatic, they have not received much transfusion, generally what I have seen is patient generally don't take it that seriously. Now, quality of life when deteriorates initially, they are little bit more receptible to what you say. And once you take treatment and they start responding to any treatment, it can be transplant or it can be immunosuppressive therapy. Once they have a response to that, the quality is like their transfusion stops. The pack cell transfusion or the platelet transfusions or the number of infective episodes, their admissions to the hospital stops. You can really make the difference. You can say they are as good as anybody else. So once they start responding, they can go, if they're in the school going age, they start going back to school. If they're working class, they start going to their work, and they generally do well. Once we have stopped immunosuppressive therapy, they can do almost every work. We don't generally say don't do this, don't do that. We just say take precautions. If you are getting infected, you should be taking a little bit more seriously than what the other people will be doing. But we see difference in quality. So quality of life deteriorates, that they are more serious. And once they have taken seriously and when they have responded to the therapy, once their quality of life improves, you can have a visual impressions. Yes, the quality of life has improved.
Thank you.
Sir, I would like to make a comment at this point, though in a lighter vein. Actually, that diagnosis, the name of the disease itself is a misnomer. The moment you tell to a patient that you are suffering from a type of anemia, he takes so lightly because everybody is anemic in India and everybody takes folic acid, iron. So they say this is one type of anemia. Let us take folic acid and forget about it. It is the symptomatology which create problems. So I think that name should be some fancy name so that there should be some impact on the patient. Please take it in a lighter note. Okay. Dr. Sandeep, please.
Yeah, Dr. Pingle, sir, if you have any question or comment. or Dr. Tyagraj?
No comment, no question. It was a very nice presentation and we all enjoyed it. My only question was about benzene, which you have already asked.
Yeah.
Thank you.
Right, sir. Thank you. Dr. Kamla, madam.
Dr. Sir, it was a wonderful presentation. I wanted to ask you one question. Is there any government, are there therapies, and these therapies are available in government hospitals where the poor patients can go and take treatment? Like even for cyclosporin, is it available? Is there some trial or some programs going on where the patients get benefited or they can take benefit of?
Dr. Rayaz has been disconnected actually.
Okay, no problem.
So it was a nice presentation by him. In his
Yes.
absence, we should thank him.
Yes, thank him. Then I think we can take this question later on also.
Yeah.
Doctor.
So it was nice joining for this particular session, and we'll continue with our new efforts. Dr. Pawan, if you have any comment.
I think it was, yes, sure, sir. It was really good to touch upon such a topic which is like anemia, and definitely we all are aware that Honorable Prime Minister himself launched a project Anemia Mukt Bharat in 2018 April, which is going full throttle in the country as of now, and the aim is to make 450 million people anemia free by in next 2, 3, 4 years across various states. So we are very much into this domain only. That's why. And I just wanted to ask a couple of things with Dr. Ahmed, but somehow he left. But I must say,
Pawan, he has joined actually.
Great, Dr. Sharma. Then, Dr. Ahmed, if you are here, I just wanted to ask two quick things. Does it happen anytime in this with the patient that hemoglobin level goes to a normal level and the person is not anemic, even if whether it is tested at point of care or whether the sample goes to lab in this entire duration or cycle? Does it ever happen, just like other hemoglobinopathies, sickle cell disease, thalassemia, person will never be able to maintain normal hemoglobins?
No. Once they respond, once they start responding, they will attain normal hemoglobin level, what was their pre-diagnosis.
Okay, so over it is post-treatment. But I'm asking if at all they are. Oh, sorry, please, Dr. Ahmed, please go ahead.
So the response can be anything. Complete responses do happen. It's not like that my pre-transplant hemoglobin, transplant or pre-immunosuppressive therapy hemoglobin was 14. Post-treatment, my hemoglobin will again reach to 14 level. Sometimes we see overshoot, but it's not like that. It always does. It can be like, it can be in the range of 11. It can be in the range of 12, but that is compatible with life. More than 8, we say no need to transfuse. You can have a normal life. 8 is enough. But majority of the patients will have more than 10, 11, and at least 30-40% of the patient will be what their normal hemoglobin was pre-diagnosis. They will achieve that.
Okay. So that is
one more question. Actually, I heard from ma'am that is there any government agency who is helping out with this with cyclosporin? I will tell you, there is sorry on my part, I couldn't tell you in the my presentation. There is a Coal India project which is there in by Government of India. It's actually started to help children with thalassemias, those who require blood transfusion again and again, to undergo transplant. Generally, this Coal India project will give child up to 12 years of age, those who have got HLA match sibling, they generally are giving 10 lakh rupees. If they have HLA match sibling, and Rajiv Gandhi is one of the institutes where this facility is available to undergo transplant. Lately, they are going to include aplastic anemia also. So if this aplastic anemia comes into this, and most likely we have received the official letter that aplastic anemia is going to be, severe aplastic anemia is going to come into this. Those people who are having aplastic anemia and they have got an HLA sibling, they will get around 10 lakh rupees. So that's a huge help from the government side. Now, this is for
Yes.
transplant. Now, for immunosuppressive therapy like ATG, which will be costing in 5 to 6 lakhs, and cyclosporine, which is going to cost 15,000 per month for another 1 year or 2 years, on Eltrombopag. Now, Eltrombopag, the company helps by giving some patient assistance program that can be taken. Cyclosporine is not available. It can be available at lower prices in AIMS, but that is in Amrit Pharmacy. I don't think so anywhere in country. And there are different brands available. You can have a lesser, but no hospital is or no government is giving. Now, what in the for immunosuppressive therapy, government of India, when you apply to Prime Minister office, like they can generally get help if the hospital is approved for that from the Prime Minister office to get this facility. They get monetary help of around 3 lakh rupees. So Rajiv Gandhi is one of those hospitals. Patient applies for this Prime Minister fund or Chief Minister fund. Generally, they get some monetary help, and patient can buy medicines with those things, and it can be used in transplant also. And for the transplant, Coal India project is there, which was initially helping us for the transplants for thalassemia patients. Now it will be going to help the aplastic anemia.
Thank you, Doctor Sir. Thank you very
Thank
much.
you. Thank
So, Dr. Rayaz, this is under CSR project.
Yes, this is CSR project. Yes.
Okay. So this is a good project. Like Dr. Kamla Fartial, she is GM Medical from NHPC, and our President, Vice President, they are from Indian Railways, and I'm from Indian Oil Corporation. We can look forward for these sort of CSR projects for our people.
Sure, sir. Sure.
Sudha Madam is our past president. She has joined from Chennai. Dr. Shyam Pingle has joined from Gandhinagar. He is also a past president. He is also International Commission on Occupational Health board member. And Dr. Tyagara sir, if you can have some comment, or because he has joined from Bangalore. Or otherwise, Dr. Rayaz, it was nice talking to you, and you have given a very comprehensive outlook of the aplastic anemia, and especially we all in industry, in chemical industry specifically, we need to be aware of all these acquired type of aplastic anemias also, because this is a very common thing, and people, they do complain of fatigue and all these sort of things, and we do regularly do the periodic medical examination, but we should be aware of the screening and the diagnosis of aplastic anemia, and accordingly we should be aware of the treatment modalities also. That was the reason why we wanted to have a session with you, sir. And
thank you, sir. My pleasure.
We have a lot of good friends with Rajiv Gandhi Cancer Hospital, Dr. Sudhir Rawal, your onco.
Yeah, he is now medical director.
Yeah.
He's MD, managing director, sorry.
CMC Vellore also, he has done.
Yeah, he's also from CMC Vellore.
We have worked together, so
okay,
a lot of good relations with your faculty in Rajiv Gandhi. So it was a nice presentation, sir, and as a token of respect, we have designed a small certificate appreciation.
Thank you, sir. Thank you very much.
We'll send it to you by email, and so thank you very much, and for nice to join with you, and we'll keep in touch, and we'll have many more sessions with you, like when we come out of this COVID pandemic, when we start meeting physically.
So, sure, sir. Sure. Looking forward to it. It was nice meeting here.
Yeah, we all, our association IOH is a very active across India, and especially in Delhi also we are quite active, and we'll look forward for meeting with you.
Sure, sir. Sure. Thank you. Thank you, sir.
I also like to thank Novartis for.
Thank you all.
Thank you, sir. Thank you very much.
Thank you, Delhi team. See you next week.
Thank you very much, ma'am. And thank you to Dr. Rayaz.
Thank you, sir.
Thank you, sir. Thank you.